Right, we'll kick off. So thank you very much to everybody for joining us for this webinar. Thank you for giving up your evenings, and in anticipation, thank you for the work which it sounds like you're keen and happy to put in. We'll start with some introductions and then we'll get going. We are recording this so that we can put it on our website, and people who weren't able to join this evening could watch it at a later date. So just to say that we're recording this. And as mentioned, I think what I'll do is if I introduce just a few people, and if anybody else wants to ask any questions, perhaps introduce yourselves, or comments, perhaps introduce yourselves at that point, if that's okay. So my name's Andy Giorgio. I'm a consultant in intensive care and anaesthesia in Bath. I'm clinical director for the South West Critical Care Network. And I'm joined by Martin and Dave, and I'll let the two of them introduce themselves. Can we go, Dave?
Yeah, sure. Dave Kane. I'm a critical care and anaesthesia consultant in Truro, and I'm the Peninsula Sub-Region Lead for this critical care network in the Southwest.
Hello, I'm Martin Schutz-Bruce. I'm an intensivist at University Hospitals Dorset, and I look after the hospitals that are part of the Wessex Rural Care Network but fall within NHS Southwest. So that's University Hospitals Dorset plus Salisbury and Dorchester. Thank you.
Thank you both. So for the purposes of this evening, we're the representatives of the Southwest Critical Care Network. And for those of you who don't know, the Southwest Critical Care Network is the sort of arm of NHS England that reaches out to all of your units in the region, and we're responsible for sort of pulling people together, for collaborating, coordinating, and also for being the conduit, if you like, between units on the ground and NHS England. So that's our role. And Tom Bormer, I'll let you introduce yourself because you are speaking this evening.
Yes, thanks, Andy. Hi, I'm Tom Bomer. I'm a trainee in Severn and part of STAR committee, and I'll be going through some of the nuts and bolts of everything to do with the project in a moment after Andy's introduced things. So I'm sort of representing Severn and STAR tonight. I think Tom Woodward's also just tuned in. He's representing Peninsula side of things, and at the next webinar there'll be someone from Spark. Unfortunately, they couldn't make it tonight, one of the trainees, but we could pass on any questions that you might have to them. Thank you.
Thanks, Tom. Okay, without much further ado, I think we'll just get on with the nuts and bolts of the webinar this evening. So this whole project has come about really because the Southwest has the fewest number of critical care beds per head of population of any other network, with a possible exception of the Southeast. And there have been many attempts over the years, particularly after wave 1 in 2020, to try and level us up, if you like, and to try and get the Southwest at a similar footing to many of the other parts of the country in terms of beds per 100,000, critical care beds per 100,000 population. There's been varying degrees of success, but we still, pending the stocktake, which is about to be published any day, we're still in the bottom 2 in the UK, in England, for the number of beds, critical care beds per head of population. Now, the attempts to correct that in the past have been valiant, but the trouble that we've always come across is that we haven't been able to prove or show that patients in the Southwest do any worse because we have fewer beds. Our ECNARC outcomes are all very good across the Southwest. Our quality indices are all very good. And so it's difficult really, I suppose, for people with the purse strings to understand what it is that we hope to achieve by having more enhanced or indeed critical care beds. And that's where this project was born from, really. It's understanding what is our patient need and how, if at all, our patients in the Southwest are dealt with any differently to patients in other parts of the UK. and whether or not there's an opportunity there to improve the quality of care that we can provide. So that's where this project was born from. I'm going to share some slides at this point. Okay, so working together with Swarm and STAR and Spark, we have come up with this service evaluation, which we've catchily named PEACH, so the provision of enhanced and critical care for high-risk patients in the Southwest. And it's been a great pleasure working with Swarm and STAR and Spark, and of course through them we're very much hoping that you as trainees are going to be able to support and help deliver this project. There's not been anything like this done before, but what it is going to be is an enormous data exercise, which for the very first time is going to show how we're forced to make certain decisions for patients in the Southwest, given the resources that we have available. So what we're hoping to do is understand what proportion of patients undergoing surgery have a need for post-op critical or enhanced care, and understand of those which patients actually receive it. And by understanding the difference between supply and demand of enhanced and critical care, we can understand where in the Southwest we have the potential to do things differently, or indeed do things better potentially. So that's kind of one half of the project, is a perioperative service evaluation, and it's looking at patients' enhanced and critical care needs and which of those patients receive those services. The other half of the project is to look at critical care on its own and look at, try to understand how the decisions to admit or refuse patients to critical care are underpinned by the constraints and capacity that we have compared to other networks in England. And I think this is quite an important aspect of the project, because of course you'll all probably know that for any given critical care unit, you can only work with the beds that you've got. And I work in Bath, and my threshold to admit or refuse a patient who could potentially benefit from critical care changes according to the capacity that I have available. And it shouldn't be like that. I worked in Australia, and it certainly wasn't like that in Australia. So we're looking to try and understand that, try and understand what happens to those patients who are in that grey area between do not and do require critical care. And once we've got all of this, we're hoping to feed that into the discussions that we will be having with integrated care boards. So they are the people, increasingly so, who are going to be holding the purse strings for enhanced and critical care provision in the Southwest. And the Critical Care Programme Board at NHSE, which is a sort of central command, if you like, for critical care in England. And they've been fundamental to doing many of the things which you will have appreciated since COVID. So, for example, set up a transfer services. So that's what we're hoping to achieve. They're our aims. We've been through the necessary approval steps. So this isn't research, it isn't audit, it's not formal quality improvement. This is a service evaluation. It's a multi-centre service evaluation, and it's been approved as such at the hospital I work at in Bath, and they've been very clear that no hospital requires any form of approvals. But despite that, we have notified all Caldecott Guardians in the Southwest by writing to all medical directors. And we have written to the clinical directors of anaesthesia and critical care in all of the hospitals in the Southwest, and they've all agreed to support the project. So at this point, I'm going to hand over to Tom, who is going to talk you through the nitty-gritty of what is going to be required in order to make this evaluation a success. So Tom, over to you.
Yes, thank you, and thanks for everyone who's tuning in tonight, who's already signed up or shown interest. And for anyone that's not yet signed up, hopefully I can convince you to do so by going through this all in a bit more detail. Some people might have already read the guidance document, so apologies for going over anything that you might already know about, but I'm going to just try and bring everyone up to scratch on the same level of detail. As you'll know by now, it's going to be a 7-day project, so running from 8 AM on the 6th of November until 8 AM on the 13th of November inclusive, so that's Monday morning to Monday morning. And there is a plan B, so if there's a strike declared, I don't know anyone on the committee, so I don't think the dates have been announced yet, but if that happens, we will move things to the week afterwards, starting at 8 AM on the 13th of November up to the 20th. And we'll have to do some juggling in terms of who covers what days at that point. But now we've got the momentum, we don't want to abandon things last minute. So there's 2 arms to the service evaluation, which we're planning with Peach. And I'm going to go through each of those in order. So it doesn't really matter which order, but I'm going to focus on the critical care side of things first, because perhaps that is a little bit more complicated to get your head around. The critical care arm, as Andy pointed out, is to look at some of those nuances around patients that are referred, and out of those, how many are admitted and how many aren't admitted, and the reasons for that. And as well as that, looking at the number of surgical patients that were planned to come into ITU but had to be cancelled because of a lack of critical care beds. And they could have been cancelled anytime, even though they were booked for that particular day, they could have been cancelled at any point in the 72 hours prior to that due to anticipated lack of capacity. So in terms of how this is going to work, I'll show you the QR codes on the next slide in a second. There's going to be 2 daily data collections. So there's going to be in the morning at 8 AM and then in the evening at 5 PM. As the STAR local leads or collaborators, we're anticipating that your role is not necessarily to do the direct data input. It's more as an overseer, as a query troubleshooter person to facilitate the process. And there may be different consultants as changeovers happen throughout the week. So I think we're going to need a daily presence. Well, we are going to need a daily presence at 8 o'clock and 5 o'clock to make sure that we're not missing these important data collections. And it's maybe slightly easier in smaller units. In places like Southmead or Derriford, it may be where there's multiple consultants, maybe a little bit more challenging. But I think we're going to need to be fairly proactive from this point of view in trying to achieve this. So I'll show you the QR code in a second, and all of this data from the QR code links onto an electronic form, which I again can show you at the end. There's one QR code for the 8 o'clock and one QR code for the 5 o'clock, and you can see those here. The idea being that the morning data is covering any referrals since 5 PM the previous day, whereas the 5 PM evening data covers any referrals since 8 o'clock the same day. And what I'll do when I get to the point of showing you the form, I'll talk through the kind of specific information that we're going to be entering. The other thing is, as well as the QR codes here, Andy, sorry if it's all right to go back to the previous slide for 1 second. So we're going to be collecting number of referrals, as I said, and then number of surgical patients that are cancelled, and the number that are admitted and the number that aren't admitted to ITU, and the reasons for those, which is what we want to try and look at in a bit more of a nuanced way to get that information. The other thing which isn't included in these QR codes or these electronic forms is looking in a specific way at patients that were booked but were cancelled. And what we're going to ask the you guys as the local leads and collaborators to do is to use a separate QR code, which we're not going to put up on ITU because it will lead to confusion, but a separate QR code which we'll make available to you, which will then enable specific data to be entered on each patient that is cancelled, who was booked as a surgically booked bed, post-operative bed. So there should only be 2 or 3 patients like that each day maximum in each hospital site. So it shouldn't be hopefully a massive data collection burden. And in fact, that's the only data that we're asking our local leads or collaborators to directly do the input for. Otherwise, it's all overseeing other people doing data collection. And the data that we're collecting on these cancelled cases will very closely mirror the same sort of data that we're collecting on the patients that we're collecting data on in the perioperative arm as well. So hopefully that makes some sort of sense. Will hopefully become a bit more clearer as well in a second when I show you all the different forms, but I'm happy to take any questions at the end. The other arm of the study, so as well as the ITU arm, is the perioperative or theatre arm. So with this one, we're looking specifically at patients who are 18 or older. It's all patients who are having an interventional procedure, which could be surgery or it could be some sort of IR procedure as well, under the care of an anaesthetist, and that's the important thing. So as long as an anaesthetist is present and there's an anaesthetic chart, it doesn't matter if it was under local, regional or general anaesthesia, and as long as they need a post-op bed, those are the patients that we're including. And that includes elective, expedited, urgent and emergency cases. There are some exclusion criteria, so any obstetric patients, cardiac surgery, paediatric patients under 18, and then also day case surgery. With day case surgery, the only caveat to that is that if patients end up having a complication and need a post-op bed, then they become included in the study. So that is just the only thing to point out. And moving on to talking about the data collection process. So as we already mentioned, we have made the clinical director of anaesthetics in each hospital aware of all of this, and they've had updates with the guidance notes and the posters throughout the process. Each hospital, so although things have been sort of fairly top down so far, in terms of how the actual finer details of things work on a day-to-day basis in each hospital is going to depend slightly on the different hospital setup. And so we're going to allow you guys to look at that in a bit more detail and think about exactly how things are going to work best for you. There are some aspects of it that are relatively standardized. So obviously the QR codes and the data collection forms and the timings. There's the Google spreadsheet for signing up, which I think people have already started to fill up nicely since rotas have come out. And obviously we're looking for one named collaborator, minimum of one named person responsible for overseeing the data collection on each day of the study in every site. And so they need to be aware of the guidance notes and the checklists as well, which have been sent out. And the idea is that, so there's 2 ways in which we can collect the data. The data is going to be collected by the anaesthetic teams, and that could be the consultant in each theatre or a trainee of any level. Probably needs to be someone medical just so that they understand all the different aspects of it. And the idea is the first line primary plan is that we'll strongly encourage people to use QR codes, just because that avoids having to use the paper form, which I'll show you in a second. Because if we use the paper form, we'll then have to copy that into the electronic form, and so it avoids that duplication of the data, which adds extra workload. So really, the QR code is the kind of plan A for people that are happy to use it. If there's anyone that is sort of unable to access the QR code, or there's a technical problem, or they're just a general technophobe, then there is always the option of giving them a paper form, which we can upload later. But as I say, we're going to try and talk people out of doing that where possible. But we're trying to make, the idea is that we're trying to make it as easy and accessible as we can, so there is always that plan B if needed. In terms of the actual electronic form, I'll show you that in a moment and go through that in a bit more detail. The QR code, so what we're going to ask you to do is put up a QR code in every theatre on the anaesthetic machine, and as well in the coffee rooms and around theatres, just to make it as easy as possible. We don't want to put the QR codes up until a few days before, so because we're starting at 8 AM on a Monday, putting it up probably on the Friday afternoon where possible is the best idea, so that it's ready to roll for the Monday. Depends who's available to do that. And ideally, if possible at each site, if someone's able to test the QR code with a few kind of dummy entries beforehand as a sort of pilot study, just to check that it definitely works in the hospital and using the hospital Wi-Fi, and make sure there's no problems that need to be addressed beforehand. That would be really helpful if people could do that at each site. Those are the main things to say. We've put here at the bottom about patients being cancelled, but my understanding is that we're not putting cancelled patients into the theatre arm anymore. We're going to be, I don't know, Andy, would you be able to just confirm that point?
Yeah, thanks, Tom. I think if there's any concern about it, I think it's probably easier just to, I think if a patient is cancelled, it's probably easier just to scan it and enter them and just write that they're cancelled in the comments box. It's going to make it easier for us to tally up the numerator and the denominator data at the end of the day. So I think if a patient is listed for surgery with a post-op bed, they fulfill inclusion and exclusion criteria, and then they're cancelled, I just put them in and write they're cancelled, and we can sort it out at the end.
Yeah. Thank you. And there might be some overlap with that in terms of, because we're also collecting the data on, as I said before, patients that are booked for ITU but then get cancelled. So there may be some overlap there, but that's fine. We can work that out when we get to the data analysis. So that's the kind of main thing to say from that point of view. If you don't mind going to the next slide for a second. So this is what the poster is going to look like for the perioperative arm. So this has got the inclusion and exclusion criteria, obviously. It's got the QR code, which is the same QR code across the whole of the Southwest. So it's going to be the same code every theatre in every hospital, and that links to the electronic form, which I'll show you in a second. Otherwise, I think those are the main things to say from the slides. I think there's a few contact details on the net. Oh, sorry, yeah, I'll just mention, so things that we're going to supply you with. So some of these have already gone out, the checklist and the guidance document. The QR codes will send them out much nearer the time, probably a couple of weeks before. The ITU QR codes are to go up, obviously, in intensive care, not in theatres, and the perioperative arm ones to go up in the theatre suites and specific anaesthetic rooms. If people are able to start putting up the promotional posters around about now, I think that would be a good way to go, just because we've only got about 6 weeks left. So the sooner we can start trying to spread the word and advertise as much as possible, the better. And the final thing which we're going to distribute is the paper Plan B data collection form for the perioperative arm. So we'll send copies of these out to people locally. I think the latest on this is that if copies are needed, they may need to be photocopied locally to distribute those as people need them. And I can see Andy nodding on that one. And these are just some contact details. So we'll provide finer details nearer the time about if there's specific major issues that come up, who your first point of contact is on each day of the study, and also who your kind of local point of contact is in the region, if there's kind of minor things that need to be discussed, if there's queries. But for now, these are your main phone numbers and email addresses for getting hold of people. So what I'm going to do, I'm going to share my screen if that's okay, and then just show some of these other forms and documents quickly. So let me know if, can you everyone see this okay? So this is the sign up sheet, which hopefully people have seen already. So it's starting to fill up, which is great. So we're getting lots of people across all the different hospitals in the region, in all of the different regions, sorry, and including Saturday and Sunday as well. And if anyone's got any questions about the sort of dedicated non-clinical time for this, we can talk about that in a second. This is the main promotional poster, which should be aiming to get up in all of the different hospitals now and send out on different WhatsApp groups. So this has the dates, the aims of the study, and how we want people to help. And if we could put these up in coffee rooms and just try and get it at the forefront of people's minds, that would be brilliant. With the electronic form, so I'll do it in the order that that I've just talked about it. So with the intensive care arm, there is the morning data collection. So with this, to make it work smoothly, we're recommending that probably the first place to go in the morning at 8 o'clock is to intensive care and be there for the handover, because you're going to need that information from the person coming off the night shift. In some hospitals, there may be separate rotas for trauma and referrals, but all of those are included. And by being there at 8 o'clock, you can get that data before the person goes home and that data gets lost, and we can get it into the form at that point. And then, as I said before, that includes all referrals since 5 p.m. the previous day. So it's got the hospital, the date, the number of urgent or emergency referrals, and this includes cardiac arrest, trauma, ED cases, ward referrals, and theatre cases that weren't originally booked but may have had some sort of complication either in theatre or in recovery, or once they've gone to the ward and end up needing to go to ITU. And we might change the wording on that just to make that 100% clear, so that people know that it definitely includes those ward patients and theatre patients that weren't originally booked as well. The number of referrals that are admitted out of those referrals that were flagged up, and out of those that were admitted, how many were delayed by more than 4 hours. And then you can see there's an option here. So this is where we're looking at the kind of nitty gritty of why were patients, if they weren't admitted to ITU, why were they declined? And there's a few different options. This is quite difficult to capture in a survey, because there's a million and one reasons why you might not bring someone to ITU, but we've tried to distill it into the broadest categories possible in a way that won't affect things from a medico-legal point of view as well. So that's there. You can see if there's more than one patient and you've entered the data, a second one comes up, and then potentially a third, and as many as you need. So that's the morning ITU arm. With the evening intensive care arm, you can see here, so this is covering referrals from 8 a.m. till 5 p.m. that day. It's very similar to the morning one, so I'm not going to go through all of that again. The only difference is when you click on this at the bottom, you get more options, but if you say there's no other referrals, it comes up with a few extra questions. And this is where the information on the number of critical care beds which were booked for elective post-operative patients today gets entered, and then the number of planned operations that couldn't proceed and were cancelled due to a lack of critical care beds which were staffed, we put that number in there, and then any further comments as well. And like I was saying before, there's going to be a separate QR code and form which we're going to, as the local collaborators, enter the data ourselves into for cancelled patients, which we'll send out at a later stage. And the data for that will very closely mirror the perioperative arm, which I'm going to show you just about now. So this is the main electronic form for the theatre or perioperative arm. So I'm going to just put in some made up data just so I can go through the different pages. So I'm only doing this because otherwise it won't let me go on to the next page. So it won't be as useful for everyone listening. So you can see, what I forgot to say is that a lot of these questions on this form essentially link to the SORT score, which is what we're using to underpin all of this, because it's those high risk cases on the SORT score with a 30-day mortality above 5% that will be the ones that, according to national guidelines, should come to intensive care. And so that's why this form reflects a lot of the SORT score. In terms of which procedures to include, so if you can't find it on this drop down, and again this drop down all comes from SORT, then it probably isn't a case which this is an exhaustive list. So there's the option to enter the operation and then a subcategory, and then it has all of the different procedures. So if you can't find the procedure on there, then it probably doesn't exist. And then the original plan for your post-op destination, any intraoperative complications which might lead or warrant an upgrade in predictive post-operative care. So that could be surgical, medical, or anaesthetic, as long as it's intraoperative. Question 15, which relates to patient anaesthetic surgical factors which might make enhanced or a critical care bed beneficial for this patient. And this question is a subjective global judgment by the consultant that is looking after the patient, the anaesthetic consultant primarily. And then the ultimate post-operative destination where the patient is predicted to go to. This data will be entered ideally towards the end of a case in theatre. And so when we say the ultimate post-operative destination, that is the destination that is anticipated at the end of the case. And that obviously could change once the patient goes to recovery, or the patient could end up going to the ward and then deteriorating. We're not going to worry about that too much because things are always dynamic and we don't want to overcomplicate things. And then at the very end here, there's just a couple of options for entering mortality scores if they were calculated on which scoring index. Those are optional extra data. And then any comments, for example, if the case was on the list but then cancelled. And then once you've put all of that in, you should get a thank you. And that's one of the cases done for the perioperative arm. The only other thing I was going to say is that in terms of actually making this process work with lots of theatres trying to do this at the same time, we're very much leaning on the anaesthetic teams to do the data input. And so we've tried to make the form as relatively straightforward and user-friendly as possible. I think whoever the local lead is for the day, or the collaborator for the day, is going to need to go round those theatres at least once in the afternoon and at least once in the morning, just to try and prompt people and troubleshoot early. But if possible, to do that more than once during the morning and the afternoon as well, just to make sure we're not missing any cases. And one option might be to have a list of all the cases in all the different theatres and to go around and try and tick them as people say that they've been entered, so that we can make sure that we haven't missed anything. But I think essentially we're leaving it to you guys locally to work out the best way in which to do it, because it's going to be a bit bespoke depending on the hospital. And those are the main points which I was going to cover. So if anyone's got any questions, happy to open it up to the floor, or if Tom or anyone else has got anything to add first. But thank you. Thanks very much.
Thanks, Tom. That was very comprehensive. Thanks very much. I think you're sharing your Teams screen. Yeah. So I guess, I'm just going to, let's pause now for questions. I'm sure there may be some questions. So let's see. Anyone got any queries? completely stunned silence.
I'll ask a question, Andy.
Okay, come on, Dave.
How are we going to reward our hardworking trainees for their involvement in this project?
Yeah, great. Yeah, good. Thank you. I was coming to that. It's very, very important that if you're involved in this project as a trainee, that your name appears on one of these spreadsheets, because this has never been done before. Never before in the UK do we know on a complete suite of patients coming through an entire network will we know what perioperative risk patients undergo, what are the decision makings around where they go. This has never been done before. We're going to write this up, and so long as your name appears on the spreadsheet as a local collaborator, you will be linked as a collaborator on PubMed. So it means that although your name, because there's going to be lots and lots of people, although your name may not appear at the top of the paper, your name will be linked to that paper through PubMed. And for you, that counts as a publication, a research publication, which is generally quite hard to get, I think, as a trainee. So long as your name appears on a spreadsheet somewhere that these boys have very kindly got together, we'll be able to link you as a collaborator on PubMed to any publication or presentation, and that counts as a publication for you. So please make sure your name's on a spreadsheet. I've got, hang on, we've got a question. Hold on, I'm trying. So, Bahil, have I said your name correctly?
Yes, it's a,
Okay.
yeah. Good evening, everyone, and thank you, Tom. I have a little bit question regarding the QR code for ICU. So I a little bit get confused, because what I understand that in the morning at 8 a.m. should enter the data over the night, but on the electronic form it says that collecting the data since 8 a.m. So does it mean since 8 a.m. so it's over the night or in the morning of the day? So it's a little bit confusing, just to clarify that.
Yeah, I can pick that up. That's a really good question, thanks. Basically, intensive care data is collected twice a day at handover. So
Yeah.
it doesn't really matter what, we've said 8 a.m. and 5 p.m. because probably across the region that matches up with handover. But basically what we're looking for is the data to be collected at handover in the morning. So before the night team go home, they've got all the referrals that they've received in their heads, and we can capture that. And then another one at 5 p.m. so that any referrals that happen during the day can be logged in the evening. So the first captures from 5 p.m. to 8 a.m. and the second captures from 8 a.m. to 5 p.m. So between those two codes, you capture the full 24-hour period and all referrals that have come into ICU over a 24-hour period.
Thank you.
Does that answer your question?
Yeah, because the title for since 8 a.m. it's confused me. So I don't know, it's the start or the end for it.
Yes, okay. So at 8 a.m. you're just looking at all the patients who've been referred to you since you last did the scan the QR code at 5 p.m. I should say at this point that I was going to come to it as I sort of summed up, but as a group of trainees, there's actually very little, if any, data collection that you need to do. What we're really asking you to do is to prompt the ICU team to do the ICU one, and to prompt the anaesthetists to do the theatre or the perioperative one. The only data that we need you guys as local collaborators to collect directly is if there's been a cancellation of a surgical case because of a lack of ICU bed. Under those situations, there's another QR code, That's the only information that you need to collect directly. Everything else is just prompting the other teams. Okay, any other queries? Thank you very much, Tom, for addressing those queries in the chat. Martin's, yeah.
Yeah, when I was just sort of listening through to it all, the collecting all the cases that don't come into the ICU. I mean, I think it'd be useful for local collaborators to just brief people what those questions are going to be to the ICU consultants beforehand, because if you're including all the cardiac arrests that don't come, I suppose they've got to survive to come, haven't they? So there's got to be a decision there. But there could be quite a number of referrals. And if at 5 o'clock it's suddenly sprung on them that they've got to remember all the cases that they've been spoken about during that first day, unless they've sort of kept some sort of personal record of that, they might somewhat struggle to capture every single referral. So it's just a thought as I was hearing the presentation.
Thanks, Martin. Yeah, very helpful. Catherine, so just to answer your question about GCP, no, it's not necessary. It's not research or audit. It's a service evaluation, so the trainees don't have to have GCP. Any other questions?
There's a question in the chat
Kate.
from Ruth, actually, I think, about checking the number of entries per day per site. Who can answer that one?
Yeah, I just made a little response there just to say that we're going to get all of the data in live from our spreadsheet, so we'll be able to check on that. And if there are any errors that local teams pick up that they want us to adjust in the data, they just drop us an email and we'll be able to edit it in real time.
Yeah, thanks, Tom. It's a good answer. We will be keeping an eye on things live, as Tom says. So if there's suddenly a big void from a hospital, then we'll be on the phone to somebody to see if we can't sort that out before it goes too far. Kate Bell.
Hi, this is a logistical question, mostly about study leave. As we all know, study leave is pretty hard to come by. And I wondered, whilst I was listening to this, whether maybe people, do you think it would be okay to request a morning of study leave only? And then you could do the follow-up at the end of your afternoon list if you had a theatre list. Do you think that's reasonable, or do you think that would be unachievable to do enough follow-up in the morning to get the data that we need?
Yeah, thanks, Kate. It's a really good question. So we've written to all the clinical directors and we've said to them that, this really is an opportunity for trainees to tick the sort of research, audit, service evaluation, management box, and that really you should be freed up in order to deliver this. Now, whether and I think how that happens in practice is probably down to each local hospital to agree the best way. Now, if you have a chat to your clinical director and they say, look, we want you to request the study leave, then we would really hope that that is approved. And if it's not, please come back to us, because we could give the CD a little nudge, try and encourage them in the right direction. But it might just be that, for example, they say to you, look, we're going to put you on a doubled up list. You go around and do the stuff, the prompting on ICU and the prompting in theatres. Probably you'll be done at 10 and come back and join us on the list, then that's fine too. So how it's actually delivered at a local level, I think, is up to you to discuss with the clinical director. But we're very, very happy to support you if you feel that isn't being well received or isn't going in a positive way.
Kate, just adding, I spoke to our college tutor about this, and I mean, he was very positive that this meets the criteria that you need to claim for sort of education development time. But as you say, there's a limit to how much of that can be handed out on any one day. He considered this very much fulfilled the criteria needed to have that granted. Thank you.
Thanks, Martin. That's very helpful. Tom? Sorry, Tom, just before you come in, Kate, has that sort of addressed your query?
Absolutely, yeah, really helpful to know that we're supported, but also if we can't get the study leave, that booking onto a long case would probably be a feasible solution to that day if we have that gap in the 7-day rota.
Yeah.
Thank you.
Thanks, Kate. Tom.
So there's just a couple of points. So one was to add to the thing about the encouraging people to sign up and what we can hopefully reward them with at the end. Also, we've said, I don't know about in Peninsula and Wessex, but we've said we'd be happy to fill in assessments for people which they can link to stuff on the curriculum if that's helpful, if they just want to put in some details at the end about what their role was and what they did and that sort of thing. And then logistically, I guess it was a question actually, which is something I was thinking of today, is just how we're going, because people will probably be able to cover from 8 in the morning till after the 5 o'clock ITU collection at sort of 5:30, and then might have to go home for various reasons. So it's just thinking about how we're going to cover evening cases if there's overruns, and maybe that's something to work out locally from hospital to hospital, but it happens quite a lot in some hospitals.
I think, as Andy said, that the role of the local collaborator facilitator is there to basically prompt, as I said, the actual data collection. We're hoping that the anaesthesia team will be doing. So we're not expecting. I'm certainly not expecting a collaborator facilitator to be on site 24/7, but someone to be around to just basically get the message out. Because I think once people have got the idea that they've got to start to scan these QR codes for every case, then once they've gone through it once or twice, then hopefully they'll do it, through the whole study period or evaluation period.
Thanks, both. Kate, is that a legacy hand? Or is there a new question? Sorry. Yeah, no worries. I think at this point, I just want to sort of just sum up and just see if there are any other queries after I've done that. So thank you, Tom, very much for your presentation. So this has never been done before. We don't know the acuity of patients coming through our hospitals, not in the Southwest, not in anywhere in England. We don't know the acuity of patients coming through, and we don't know where they're cared for afterwards. Now, many of you will be aware of the national guidance that says if your predicted mortality is between 1% and 5%, you should be looked after in enhanced care. And if your predicted mortality is over 5%, you should be looked after in critical care. We have no idea the predicted mortality of surgical patients coming through our system. And we have no idea what proportion of those patients get looked after in enhanced or critical care or the wards. So this is going to unpack that for the first time ever. And given there's only 3 hospitals around the region that have enhanced care, I think there's going to be a significant mismatch between what we hope and what we actually deliver. In addition to that, we do, as I've mentioned before, we've got fewer critical care beds per 100,000 than anywhere else in the UK, with the possible exception of the South East. So it's going to be very interesting to see what our patients' needs are and what they get in terms of post-operative care. And finally, it's the first time that anyone's tried to unpack the decision-making about whether or not a borderline patient comes to critical care. And so this is the first time that anyone's tried to sort of unravel that decision-making. So this service evaluation, it has been thought up by us all, Southwest Critical Care Network, but also STAR, SWARM and SPARK, and it's fundamental. It's fundamentally a trainee-driven project because there's no chance on earth that we'd be able to deliver it without all of you. So in advance, thank you all very, very much for your interest and your enthusiasm. Really, really grateful in advance for that. What we're asking of you all really is not a huge data collection exercise. What we're asking you is to prompt other people to enter the data as appropriate. So yes, there's a phase where we'd hope you'll put up some posters and so on beforehand. And in the week of the study, it's about popping into ICU and prompting data, scanning the QR codes before handover is completed. Then coming up to theatre and going theatre by theatre and asking people to scan the QR code for anyone that meets inclusion and exclusion criteria. The only data that we'll be asking you guys to collect as local trainees is the cancelled surgical case due to a lack of critical care bed, and a bit of information around that. As I've mentioned, you're all collaborators, and in any publication you'll be recognised as such, so that counts as a publication in your name. And we have a checklist and guidance notes. So if any of this hasn't made sense, or if you can't remember what to do in the weeks coming up to the study evaluation, there's a checklist and there's some guidance notes, which we hope you've received, but if not, we'll send it on. And the last thing I just wanted to say is once again to thank you all, because this is a trainee project. There's no chance we'd be able to do it without you, and we're breaking new ground. So in advance, thank you. Dave.
It was just quick to say in terms of support, I think we sort of suggested we put one of us to be available for a set number of hospitals, didn't we, on the day? So there'll always be a way of escalating things. And then we thought just for the start, we might just check in with a quick phone call at the end of the day, just see how it's going for people, which is, it's not absolutely mandatory, but it might just be helpful. And that way, if there is anything that we need to change subtly, at least we identify it early. And as Andy says, thank you all.
Yeah, thanks, Dave. Good point. Martin.
I wanted to offer my thanks as well in advance. And the other thing I was going to say is that we have checked with sort of NHS-IT that we will be able to work out from each site, we believe, the number of patients that fulfill the criteria to have the evaluation done. So we will hopefully have denominator data, but we may even have a leaderboard for sort of completion across all the sites. I don't know that'll be in real time, but we do have a mechanism to find out how many patients should have had questionnaires filled in. So just to give you that reassurance. Thank you.
That's great. Thanks, Martin. Yeah, very important. Tom.
I just forgot to show them the paper form, so I was going to just do that really quickly.
That's fine. Just as you're getting that up, I should just say that we're getting loads and loads of all these things printed. So loads of QR codes, the paper forms, all this stuff, the posters, and I think, as Tom mentioned, it will be coming to you.
If there's a, I was going to say as well, which I forgot to mention because I was going to mention it with the paper form being up, that if there's suddenly lots of paper forms that are generated in one day, then I don't think the onus should be on trying to upload that onto the electronic form sort of at the time. Like, you should focus more on making sure all the data is put in some form somewhere, and then the data can be entered either by the local team, or we can come up with a contingency plan later on, but we don't want you to feel stressed out if that suddenly happens.
Yeah, thanks, Tom. That's good. Of course, there's always one of us on hand if you want to give us a ring and ask us anything. Any other questions?
I have one more. Sorry, it's Kate Bell again.
Oh, yeah. Hello, Kate. Yeah.
Just that amongst our colleagues, I feel like a bit of healthy competition is often a motivator. Is there going to be any way that through the week we're going to be able to see the number of cases uploaded in our hospital compared to others? Is that possible?
Yeah, it's a really good thought. We could
sure
do
we
that,
can work
right,
something
chaps?
out. Yeah.
I
Fairly
feel
easy
like
to
that with some chocolate or wine bribery might be excellent.
I think you're absolutely right. But I agree with you. I think a leaderboard's a great idea. So we'll take that away and have a chat about that. But yeah, we'll make that happen.
Thanks so much.
Any other questions? Okay, I'll stop recording and just finally just thank you all for your